One start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a presentation on management of upper urinary tract obstruction. And this would be presented by our resident, Dr. Shailendra Singh, and would be moderated by our faculty, Dr. MANOJ BAMANIA. So I would request Shailendra to kindly share his presentation. Yes.
Good morning, sir. Today topic is upper urinary tract obstruction management. Etiology: causes of obstruction may be intrinsic, extrinsic, congenital, iatrogenic. Intrinsic causes are congenital anomaly like PUJ or retrocaval ureter, ureteral stricture, blood clots secondary to trauma, bleeding disorders. Infection, severe infection can cause blockage or inflammation or abscess formation and stones. Extrinsic causes are retroperitoneal fibrosis, compression of masses like bladder tumor, colorectal tumors. Pregnancy and enlarged uterus can compress the ureter. Vascular abnormality like aberrant blood vessels can compress the ureter. PUJ definitions: obstruction of the proximal ureter at the junction of the renal pelvis resulting in restriction of the urine flow downward is called PUJ. Management of PUJ: investigation USG. The maternal perinatal ultrasonography has led to dramatic increase in number of asymptomatic newborn being diagnosed with hydronephrosis, many of whom subsequently found to have PUJ. CT and contrast and CT provide detailed anatomic and functional information in diagnosis of PUJ. Diuretic urinography remains a reliable study for diagnosis of PUJ. And ureteral obstruction provide quantitative data regarding differential function and obstruction. Whittaker when doubt in diuretic renography, Whittaker pressure perfusion test is done by placing a PCN, renal pelvic pressure more than 15 to 22 centimeter of water, highly suggestive of renal functional obstruction. Pathogenesis of PUJ: congenital PUJ typically result from presence of an peristaltic segment of the ureter. Intestinal obstruction of PUJ may also result from the kinks or valves produced by infolding of the ureteral mucosa and musculature. In some patients, high insertion is likely the primary obstruction lesion, and in some crossing vessel is the primary pathogenesis. Indication of intervention: either symptomatic patients, impairment of the overall renal function, progressive impairment of the ipsilateral renal function, and development of stone or infection or hypertension secondary to PUJ. Operative interventions: pyeloplasty, surgical reconstruction or revision of the renal pelvis to drain and decompress the kidney, called pyeloplasty. The goals is relief of symptoms and preservation and improvement of the renal function. Principle of pyeloplasty: anastomosis should be widely patent, watertight without tension. Reconstructed pelvis should allow a funnel-shaped transition between the pelvis and ureter, that in position of dependent drainage. Open pyeloplasty, either dismembered or non-dismembered type. Dismembered pyeloplasty is Anderson-Hines is most commonly performed pyeloplasty. Non-dismembered is Foley, YV-plasty, spiral pyeloplasty, or vertical pyeloplasty. Dismembered pyeloplasty indications are done in any condition like high ureteral insertion of pelvis, redundant pelvis tortuous proximal ureter, or obstruction due to aberrant or accessory lower pole vessels, except in conditions like lengthy or multiple proximal ureter stricture and small inaccessible interrenal pelvis. Techniques is: first identify the proximal ureter in the retroperitoneum, then speculated on the lateral aspect. In the apex of this lateral speculated it brings to the inferior margin of the renal pelvis, and the medial side of the ureter is brought to the superior aspect of the renal pelvis. If the renal pelvis is exceptionally redundant, a reduction pyeloplasty can be performed by redundant portion of the excising the redundant portion of the pelvis. Cephaloid aspect of the pelvis is then closed by running absorbable sutures, suture down to the dependent portion. Then this remaining dependent portion is subsequently anastomosed to the ureter. In event of aberrant or accessory lower pole vessels found, dismembered pyeloplasty allow a transposition of the PUJ in relation to vessels. Non-dismembered type of flap procedure are Foley biblioplasty is best done for high insertion of the ureter, and then structure of obstruction is less than 2 centimeters. Culp D-word spiral pyeloplasty is best suited for large, readily accessible extrarenal pelvis in which ureteral insertion is already in dependent oblique position. Spiral flap may be significant value when PUJ is and relatively long segment of proximal ureter narrowing or stricture occur in same setting. To preserve vascular integrity of the flap, ratio of the flap length to width ratio should not be greater than 3:1. Scardino Prince vertical flap may be appropriate used when dependent PUJ is situated on the medial margin of large square box-shaped extrarenal pelvis. Is done in long area of proximal ureter narrowing. Davis intubated ureterotomy, its lengthy or multiple structure are found in association in PUJ. The intubated ureterotomy may be combined with a standard pyeloplasty procedure. PUJ is corrected by pyeloplasty, and distal aspect of the ureterotomy is left open to heal secondarily by ureter regeneration. Intubated ureterotomy best combined with spiral flap procedure because it made longer flap which allow more of the structure area to be bridged by pelvic flap, thereby leaving a shorter area rely on the healing by secondary intention. Ureterocalicostomy, this indication are PUJ or proximal ureter structure associated with scarred or small intrarenal pelvis, also used in failed pyeloplasty or when PUJ is associated with rotational anomalies like horseshoe kidney. These techniques are incision or excision, parenchyma over the lower pole of pelvis is or must be resected rather than simply incised because simple nephrotomy can produce secondary stricture. Endourological management is done by endopilotomy, either done by antegrade or retrograde method. Antegrade method done when it is concomitant stone, which require percutaneous access, which can be managed simultaneously. Retrograde done in short area of obstruction without upper tract obstruction. Basic concept of endopilotomy is full thickness lateral incision through the obstructing proximal ureter from the ureter lumen out to the peripelvic and periureter fat. A stent is placed across the incision to left heel like intubated ureterotomy to repair the PUJ. In endopilotomy, for cutting, either use sharp knife, cold knife, laser, or in new techniques, acute-size endopilotomy. In this acute-size endopilotomy, low pressure balloon fitted with electrosurgical vial, which is activated over 2 centimeter expandable portion of the balloon. PUJ is cleanly cut by this wire, which is that is activated during inflation of this balloon, positioned across PUJ. This balloon passively stretches the PUJ and this wire is sharply cut the PUJ. The retrocaval ureter. Retrocaval ureter is a rare congenital urologic anomaly. It occurs as a consequence of persistent or posterior cardinal vein during the embryological development. Its presence will be suspected of finding with characteristic S-shaped deformity in IV or retrograde pyelography. Definitive diagnosis may be made by 3D CT imaging. Procedural intervention is indicated presence of functionally significant obstruction leading to pain or renal function deterioration. Management depend on clinical presentation, severity of hydronephrosis, impairment of renal function. Patient with mild hydronephrosis without renal impairment or any associated complication can be managed conservatively and follow up. Surgical intervention reserved for symptomatic cases. Surgical treatment are ureterostomy, ureteral drainage done anterior to IVC with the resection of the retrocaval segment. Pyloureterostomy, Hallis method is evident. It will maintain the evident vascular supply of the pelvis as well proximal ureter, minimize the risk of structure. This is now the treatment of choice. Goodwin techniques rarely done is in this Goodwin technique, dissect the IVC and got the ureter up and then anastomosis the IVC. Vena cava supporters, chemical or metal tube covered by psoas muscle is placed between the vena cava and ureter. Retroperitoneal fibrosis is typically characterized by presence of inflammatory fibrotic process in the retroperitoneum causes compression of the retroperitoneal structure, including ureter. The retroperitoneal fibrotic mass center around the distal aorta at the L4, L5 level and wraps around the ureter, leading to hydronephrosis by extensive compression of the ureter and interference with ureter peristalsis. In approximately 70% of patients, this is idiopathic. Among 30% patients, is identifiable cause and drugs like ergot, alkaloids are most commonly associated. Other drugs are beta blocker and phenacetin. Other causes are malignancy such as lymphoma, multiple myeloma, pancreatic prostate cancer, and radiotherapy used for retroperitoneal malignancy. Management for idiopathic, first line management is steroid with initial dose of 60 mg daily, tapered up to 5 mg daily, can be given up to 2 years. Response check by reduction in ESR and C-reactive protein. If not respond, go for second line like tamoxifen added to steroids. If not respond to second line, then give anti-proliferative agent like azathioprine or cyclophosphamide. Surgical management, if not respond to medical management, go for surgical management. Ureterolysis either by open or laparoscopic, although open surgery has been standard. Hydronephrosis may be unilateral. On preoperative assessment, the process is generally bilateral, requiring bilateral ureterolysis. When an open surgery is performed, a midline transperitoneal abdominal incision is allowed to access to both ureters. For laparoscopic or robotic bilateral ureterolysis, the patient typically places in modified flank position and reposition to other flank after the first side is complete. In surgical bilateral ureterolysis, the ureter need to be protected by intraperitonealization or omental wrapping. If ureterolysis is impossible to perform, renal autotransplant will be performed. Ureteric structure. Causes of ureteric structure are malignancy, ureter calculus, radiation, ischemia caused by or trauma caused by surgical resection, periureter fibrosis, endoscopic instrumentation, infection like tuberculosis, or idiopathic conditions. Management or endourological intervention as stent placement or balloon dilatation best result in non-anastomotic strictures. Endoureterotomy. Endoureterotomy incision is a logical extension of balloon dilatation done by retrograde or antegrade approach. And in endoureterotomy, incision in lower ureter is the incision anteromedial direction, taking care away from the iliac vessels. In upper ureter, incise laterally or posterolaterally, again away from the great vessels. Surgical. Before any surgical repair, it is essential to conduct careful evaluation of the nature, location, and length of the ureter structure. Pre-operative assessment typically include RGP, AGP, if indicated as location of length of the structure heavily influence the option for the repair. Distal upper or mid ureter structure of up to 2 to 3 centimeter can be treated by ureterostomy, and distal ureter structure up to 4 to 5 centimeter can be done by ureteroneocystostomy. In ureterostomy, in ureteroneocystostomy, if distal ureter structure is more, and tension-free water anastomosis is inaccessible and used for Boriflab and Swatch Hitch. So Swatch Hitch is providing additional 5 centimeter of length compared to simple ureteroneocystostomy. And Boriflab can be constructed to bridge the 10 to 15 centimeter ureteral defect. When transureterostomy is contraindicated, done when the tension-free anastomosis is not transureterotomy contraindicated presence of any disease process that may affect the both ureter. It's contraindicated. It is insufficient length of the donor ureter reached to contralateral recipient ureter in tension-free manner. Ileal ureter substitution useful in presence of extensive ureter loss. In this, may identified the ureter and dissect this diseased portion, a piece of ileum brought to the colonic mesentery to bridge the renal pelvis and bladder. Appendix and fallopian tube has been found to ureter substitute. The appendicle only with its own blood supply should be considered for right-sided structure when appendix is available and of sufficient length and caliber. And the contraindication for ileal ureter substitution are when baseline renal insufficiency with serum creatinine level is more than 2, bladder dysfunction or outlet obstruction, inflammatory bowel disease, and radiation stretches. Buccal mucosa grafting can be done for complex, long, reoperative structure disease at any position in the ureter. Number of small case series have appeared using this technique in open, minimally invasive approaches, most commonly is only similar to urethral repair. With an only approach, there is minimal ureter disruption and complete mobilization of the ureter can be avoided in effort to maximally preserve to delicate blood supply of the ureter. Use an omental wrap or perirenal fat to provide a vascular bed for graft for good success. A comprehensive meta-analysis compared the buccal mucosal ureteroplasty and the ileal ureter replacement. The study found that buccal ureteroplasty is success rate of 95% and in ileal ureter replacement a success rate of 85%. Additionally, buccal mucosal ureteroplasty has associated with shorter hospital stay and lower incidence of both peri-operative and long-term complication compared to ileal ureter replacement. The author concluded that buccal mucosal is effective in minimally invasive and safe alternative to ileal ureter substitute replacement for management of long stricture, especially for segments of less than 8 centimeter in length. A recent multi-institutional series of 19 patients who underwent robotic buccal mucosa grafting illustrate that early finding of this technique, median structure length of this in this series was 4 centimeter and half of the patient has a prior repair. An omental flap was seen to the graft to provide blood supply. A median follow-up of 26 months, 17 of 19 patients remain structure free. Autotransplantation done when other method of the ureter repair or ureter substitution are not feasible and when contralateral kidney is absent or poorly functioning. The kidney is harvested with maximum vessel length. Renal vessels are anastomosis to iliac vessels. Healthy segment of the proximal ureter, alternatively renal pelvis anastomosis to the bladder. Ureteroventric anastomotic structure. Several factors determine the incidence of structure formation at the anastomosis of the ureter and the intestine at the time of the urinary diversion. Factors include technique used for ureteral dissection, segment of the bowel used for diversion, and the type of anastomosis performed. When ileal conduit is performed, the left ureter is brought underneath the sigmoid mesentery, just overlying the aorta. The additional length and dissection needed for left and the possibility of angulation around the inferior mesenteric artery may lead to higher incidence of stricture formation on the left side. Risk of obstruction with a non-refluxing anastomosis is significantly higher than a refluxing anastomosis. Low incidence is seen with Wellers technique than Brickers. Management. First, assess the length of the stricture and renal function. Stricture is less than 2 centimeter, and differential function is more than 20%. On the right side, the endoscopic incision is given. On left side, is definitive repair is done. Because on left side, there's a concern of the hemorrhage because the sigmoid mesenteric in close proximity. When a stricture is more than 2 centimeter and differential function is more than 20%, consider the formal repair. And if differential function is less than 20%, either observe or go for nephrectomy.
Okay, thank you. So again, upper urinary tract obstruction is a common theoretical question also. So we can expect them in the first or second paper. Management, maybe they're in second or third paper. We all know the upper urinary tract obstruction can be due to various reasons. It could be the obstruction in the kidney, pelvic junction, pelvic junction, any other part of the ureter. And this could be either congenital or acquired. Amongst the commonest congenital causes we know is pelvic junction obstruction, obstructive megaureter, retrocaval ureter. So the acquired causes would be either traumatic post-injury, or it could be iatrogenic post-surgery, sometimes post-radiation. Sometimes it could be infective causes. In our country, tuberculosis is a common cause for urinary tract obstruction. And then it could be other causes like endometriosis in females is very important to remember, because in females, endometriosis of the ureter, because we know there is a condition called urinary tract endometriosis. Obviously, the bladder endometriosis is the commonest, and the second common is the ureteric endometriosis. And they may cause ureteric obstruction, and without any symptoms, the patient may go into cross hydronephrotic kidneys, and the kidney may be knocked out silently without any symptoms. So you have to be very careful in such patients who have endometriosis. And then stone disease, etc., can also cause upper urinary tract obstruction. So how to manage the upper urinary tract obstruction? So one is management which is done in emergency or for urgently, right? And the other is which you do it in a planned manner. So emergency procedures are done in patients who land up in urosepsis, those who have metabolic abnormalities, the patients who have acute kidney injury due to urinary tract obstruction, or later sometimes these patients who have chronic kidney disease and they require kind of a diversion urgently to get the uremia and the creatinine normalized. And then rest of the things would be in a planned manner. If the patient doesn't have these features, then we should plan out what kind of management the particular patient will require, depending upon the cause of obstruction. Right? So he has dealt with POJ obstruction, where there are various procedures. We need to know exact length of the POJ stricture sometimes, which is very important to do which kind of surgery the patient will require, right? Secondly, in POJ obstruction, because the results are very good, either you do open, lap, or robotically. Pyeloplasty is almost 100% results. But those patients who have a recurrent POJ obstruction, post-surgery, if they again have POJ obstruction, that becomes a challenging case. In that case, because the whole pelvis and that POJ junction is frozen, so you don't have enough pelvis and you don't, even the ureter is short. So what to do about that? That is important. So ureterocalycostomy definitely is one of the option. But again, if the calyx and the lower pole is not dilated, again, it's a very difficult surgery. Not only difficult, the results are also very poor. So that's why sometimes people say don't go anastomose with the calyx, but with the infundibulum, as Dr. Mallikarjun also usually says in the workshops. Then about the recent advances in when you have ureteric strictures, right? So this could be upper ureteric stricture or middle or the lower ureteric strictures. And it could be a result of many things. It could be a result of trauma. It could be a result of iatrogenic causes. And we all know with the so commonly performed laser lithotripsy in ureteric stones, ureteric strictures have become so common in recent days. And we need to take a call on how to manage these strictures. I don't know whether you are aware of or not, we have a full chapter, which is written by us only in the book, which is being published by the Urological Society of India on ureteric injuries, right? So we have written the whole chapter, how to manage a case of ureteric injury and how to deal with the upper, middle, and the lower ureteric strictures. We all know that buccal mucosal graft, as in urethroplasty, has become almost a standard of care in upper ureteric strictures, at least, right? We also presented one of our earliest robotic cases were a lingual graft uretroplasty for upper ureteric stricture, which probably has not been presented till now because they have presented a lot of cases with buccal mucosal, but lingual graft, probably we were the first. Anyway, so this has become a standard of care. So just a word about omental wrapping. Usually what we do is upper ureteric strictures, we do not mobilize the ureter totally. So what we do is we let the ureter remain in the posterior aspect where the blood supply remains intact. And then you incise the anterior aspect of the ureter and put a onlay graft ventrally. So that is how usually the blood supply is not compromised and you don't have to mobilize the ureter at all. And then either you just put a kind of a tissue, either reperitonealize it or put a omentum tissue over the anastomosis. And even if you don't put it, we have seen the results are quite good if you do not mobilize the whole ureter. I think that was, I think about and then we all know we have done almost 5-6 cases of right side upper ureteric strictures with appendix interposition. This must be around 25 years ago we presented, right? With the appendix on the right side, you can, along with the mesentery, with the vascular pedicle, you can get the whole appendix on the upper ureteric stricture and anastomose the distal and the proximal segments of the ureter with the appendix. It can be done as a tube interposition in obliterative ureteric stricture, and it could be done as an appendix onlay flap with the vascular pedicle on it in case of non-obliterative ureteric strictures. So again, this is again a possibility. Some people do with fallopian tubes also, but appendix has been done and a lot of case reports have been there. A word about autotransplantation. Yes, when everything is taken care of, you are not left with any other option, then autotransplantation is again one of the important options where we can remove the kidney from the orthotopic side and transplant it on the iliac fossa, So about the body flap, yes, body flap, if the bladder is a very good capacity bladder, you can make a very large kind of a long flap. We have done cases where we have made the whole ureter with the body flap. So because the kidney is dilated, the pelvis is dilated, you can carry the whole flap almost up to the POJ junction. So Boari flap is again a very important management option where we can take care of not only the lower aortic and middle aortic strictures, but even sometimes the upper aortic stricture, the whole aortic stricture, the pan-ureteral strictures can be taken care of by Boari's flap. Secondly, about the ileal ureter. Ileal ureter is a good option when there is the whole ureter gets strictured, particularly when we get in the patients with tuberculosis, genitourinary tuberculosis. But we have done cases where we have done spiral Monty because in ileum, there is some kind of metabolic abnormalities also, and a long segment of ileum has to be taken, and the ileum becomes a very wide lumen, and there's a lot of disparity, right? So the better option is how to make it an optimized lumen, which is almost similar to the ureter, and that can be done with Monty's procedure. And the Monty procedure, we know, you didn't describe the Monty's procedure, but it's a very important procedure where we can do single Monty, double Monty, and triple Monty. Triple Monty is the spiral Monty. We have done patients with pan-ureteral strictures with the spiral Monty procedure, where three ileal segments are taken, they are joined together and made into a lumen. And you know, the small 1-inch segment, 2.5 centimeter segments give us 7.5 centimeter ureteral length, right? So with 3 segments, you can have a 20 centimeter ureter made. So pan-ureteral strictures can be taken care of by this spiral Monty also. I think that was all about the management of urinary tract obstruction, which could be due to various causes. If the residents and the faculty have any query or any suggestion or any comment to make, they are most welcome. And those who have joined us, if they have anything to say, yes, anything?
One of the indications of ileal ureter is also that when you have extensive ureteral injuries, like ureteric avulsion, where the whole of the ureter from the PUJ till that is avulsed during a ureteroscopy. Probably ileal ureter.
Yeah, very nice. Yeah. So Dr. Neeraj made a very important point that yes, with the more of ureteroscopy being done, we have a lot of ureteric injuries. It's not only just localized ureteric stricture formation, but there are sometimes ureteric avulsion. You know, previously we used to remove the stones with Dormia basket, right? So if you have a large stone and you try to remove it with Dormia basket and pull it, there is every chance. So there, at that time, a lot of patients used to have avulsion injuries, and the whole ureter used to get necrosed because of the loss of the whole blood supply to it. So it's important that how to manage these patients. Not in immediate post-operatively, they can be managed probably by again joining the ureter. Sometimes the ureter doesn't lose the blood supply and you can manage. But once the whole fibrosis has set in, then the only option is how to replace the whole ureter. And one of the important option is the ileal ureter, as commented by Dr. Neeraj. Anybody else?
There is any indication of diversion of ureter to the skin, cutaneous diversion of ureter?
Yes, definitely. But though cutaneous ureterostomy, we used to see previously a lot, but nowadays we see very few cases of cutaneous ureterostomy being done. They are usually done in patients who could not be managed properly with the usual diversions, because percutaneous nephrostomy is the simplest thing to divert, right? And that can be taken care of. And then once the emergency or the urgency has been taken care of, you can do the definitive procedure. Cutaneous ureterostomy, once done, and revising it and doing a definitive procedure later is not a very easy task. So cutaneous ureterostomy is usually would be done in patients who cannot be managed with other types of diversions, patients who are moribund, and you think that they can continue with the cutaneous ureterostomy in the later part of their life. I think, Neeraj, do you have
There
views?
are some challenges with ureterostomy. One of the particular issues with ureterostomy is the stenosis. So previously we used to see a lot of stenosis of the stoma, especially if it was not fashioned
Neeraj, यहाँ आके बोलो.
properly. Yeah.
Yeah.
And,
Yes, yeah.
So that's why, cutaneous ureterostomy as such today is not very widely practiced as it used to be practiced once.
Yeah.
And as sir rightly said, in CA bladder cases where the patient is moribund and there are some issues with the gut, you can form a permanent cutaneous ureterostomy after a radical cystectomy.
Yes, I think these are probably some of the cases. As I said, the post-cutaneous ureterostomy, the more commonest complication is the meatal stenosis at the skin junction. So you have to make a very wide kind of a flap so that it doesn't get stenosed.
The patient has to be lean and thin. You don't want a very obese patient also.
Yeah, because it's difficult to bring the ureter up to the anterior abdominal wall sometimes in an obese patient. Yes, anybody else? So thank you everyone. We do have MCQs. Okay, so we'll go with the MCQs. Yes, this one. Yes, sir. So as usual, we'll go to the MCQs. The first question is: the most appropriate location of for endoscopic incision of a proximal ureteral stricture is lateral, anterior, medial, posterior, anterolateral. Yes? Any? So usually find the vessels which are more medially or posteriorly. So though the vessels could be found anywhere. So ideally you should get an angiography done to find out what is the location of the vessels. But yes, the least would be on the lateral side or the anterior side. So either lateral or anterolateral probably would be the best approach. So the answer is lateral. The proximal ureteric strictures are incised laterally, similar to UPJ strictures. Posterior incision is offered to UPJ obstruction patients who have failed open pyeloplasty, and distal strictures are incised anteriorly, as are strictures of the middle ureter. Okay. Surgical repair of UP junction obstruction requires a funnel-shaped transition between the renal pelvis and ureter, dependent drainage, watertight anastomosis, tension-free anastomosis, all of the above. Yes, we all know all of the above because these are of the criteria for a good pelvic-uretic junction anastomosis or the pyeloplasty. Spiral flap procedures for UPJ obstruction are used to bridge a short-length stenosis, to treat crossing vessels, to bridge a long-length stenosis for a small intrarenal pelvis, only in the presence of greater than 30% ipsilateral renal function.
Long length.
Pardon? Long length. So usually the spiral flap gives a long flap where you can take care of the whole long upper ureteric strictures. Treating crossing vessels, we all know we have to do a dismembered kind of pyeloplasty and transpose the vessels posteriorly. And I think
Prince Cardino and Culp
TB. Yeah, so he had just mentioned those, right? Which type of pyeloplasty is suitable when there is an aberrant crossing vessel? So dismembered pyeloplasty. All the other flap pyeloplasty where you do not actually dismember, that is non-dismembered, where you cannot transpose the vessels, right? So dismembered pyeloplasty. Polyviviplasty is a suitable approach when encountering high ureteral insertion, a small intrarenal pelvis, anterior crossing vessel, duplication of collecting system, redundant renal pelvis. High ureteral insertion, right? Because then you can just bring the high ureteric insertion below, right? So polyviviplasty probably. 40-year-old woman with a history of hypertension and recurrent nephrolithiasis presents with a 5 centimeter proximal right ureteral stricture following an iatrogenic injury in a recent abdominal surgery. She has had an indwelling right nephrostomy tube for more than 6 months. Her baseline serum creatinine is 2.5. Renal scan shows split function of 65% in right kidney. Her bladder capacity is found to be less than 300 ml. The next step is ureterostomy. body flap, transuterine ureterostomy, ileal ureteral substitution, autotransplantation. So she has a long 5 centimeter upper ureteral stricture after iatrogenic injury. So, and her creatinine function is also a little deranged. And the scan shows a good function on the right side. Her bladder capacity is not very high. So again, as we discussed, the bladder capacity is very good. You can make a body flap down up to that. But yes, here we cannot. Ileal ureteral substitution, because again, the creatinine is higher on the higher side. So probably it will not be the best thing. Transuterine ureterostomy would be not the correct strictures. Body flap, as I said, so ureterostomy is not possible for a long ureteral strictures. So what is left is autotransplantation. So this is one of the indications for autotransplantation there. But sometimes you can, as I said, we have done multiple cases of appendix interposition. If you have a good lumen appendix, a large, long appendix, you can put appendix as an interposition tube.
You can also put in a buccal graft also
if it's a non-obliterative stricture, you can put a buccal graft also. I think these options are not there because the question was probably very old book probably. So I think these two are viable options. Ileal ureter can be performed when the patient has renal insufficiency, inflammatory bowel disease, bladder dysfunction, radiation enteritis, and small intrarenal pelvis. Can be performed. So as we said, if it is more than 2, usually you don't. Inflammatory bowel disease, you won't. Bladder dysfunction, radiation enteritis, it would be not advisable. Small intrarenal pelvis, yes, you can.
But then you will have to anastomose it to the lower pool.
Small intrarenal, it would be difficult to anastomose with this one. Bladder dysfunction, is it? Or the small? Small. Yeah, bladder dysfunction, again, he said one of the relative contraindications for ileal ureter. So I think the small bladder intrarenal pelvis, I think should not be. If you have a good margin of the pelvis where you can anastomose the ileum, I don't think there should be any problem because the ileum can be taken anywhere, right? So it's not as the ureter may fall short, but the ileum can be taken in.
Here you will be anastomosing the ileum to the pelvis only.
Renal pelvis.
So if it's a small, very small intrarenal pelvis, technically.
Technically it is. Technically it will be challenging. No doubt about it. So retrocaval ureter results from persistent posterior cardinal veins, persistent anterior cardinal veins, duplication of IVC, aberrance of lumbar vein. Posterior cardinal vein, yes. So because of that, and because of that inferior mesenteric artery, it cannot. Is it something to do with it? No. So it's the posterior cardinal vein persistence which results in retrocaval ureter. Yes. In performing a psoas H, additional bladder mobility can be achieved by transection of contralateral superior vesical artery, ipsilateral inferior vesical artery, contralateral inferior vesical artery, ipsilateral superior vesical artery, ipsilateral gonadal artery. So yes, contralateral superior. So you have to mobilize the bladder on the other side also to make a good to have a good mobility of the bladder. And to achieve that, we have to ligate the superior vesical pedicle, right? Okay, I think, thank you. So that was all. If nobody has any question, we will just wrap up the session. Thank you, and we have a very good day. So all those who have joined us, if you can come to our meeting on Thursday, on 13th February, which is on Precision and Progress, CME on robotics and artificial intelligence, all are welcome, and you can register yourself. The brochure and the registration form is there in the group.